So I'm Dr. Julie Steck, and I'm a psychologist with CRG Children's Resource Group. And today we have 5 objectives for this webinar. The first is to identify 5 forms of anxiety disorders in children. The second is to recognize the signs of anxiety. 3, understand the possible coexisting conditions that impact anxiety, and list the steps parents and others working with children should take in decreasing and addressing anxiety. I am going to ask, well, maybe I can do it. What I'd like to do is find out who's in the audience today. So if you will let us know what your primary role in attending is, then we will get an idea of who's in our audience today. So I'll give you just a few more seconds here to respond, and then we will close the poll. It looks like almost everyone's responded. So let's see who we are today. Okay. So it looks like we have 62% of you are attending as parents, 15% as teachers, 15% as mental health providers, and 8% other. So if those of you who are attending as other want to enter your role on chat, we can reference that later on. We're going to launch one more poll before we get started. And that is want you all to respond to what do you think the most common psychiatric condition in childhood is. So if you'll please respond, we'll see what you all have to say. Okay, so we'll close the poll, and I'm going to share the results with you all. So you all are right. The most common disorder in childhood are anxiety disorders. Even though we hear a lot about ADHD, mood regulation disorders, and autism spectrum disorders, the incidence of anxiety disorders in children is much higher than these other conditions. And we'll be talking about the frequency of anxiety disorders here in a minute. I will say that anxiety disorders frequently go along with ADHD, mood regulation disorders, and autism spectrum disorders. So with that, we're going to go ahead and proceed with our webinar. Anxiety is a normal human experience. We're programmed to feel fear and worry. We need to have fear and worry in some situations. And for children, some anxiety is developmentally appropriate. We know that young children will go through, infants will go through stranger anxiety and then separation anxiety. Toddlers have fear of the monsters and dark. And in adolescence, we see a lot of shyness and self-consciousness. We also know that anxiety can be associated with physical complaints. And most of you probably remember studying the normal curve of anxiety. And I thought I had that on that PowerPoint, but it disappeared. But as you remember, the normal curve is that at a low level we experience no anxiety, but when we need to perform, such as giving a talk for a webinar, or competing in a sporting event, or taking a test, or preparing for tests, we need some increased anxiety to motivate us and keep us focused. But once we go down the other side of the bell curve, we're having too much anxiety. So too much anxiety interferes with functioning, and we are now learning that too much anxiety and stress is bad for the brain. Okay, so I just heard my PowerPoint is not okay. Sorry about that. Is it back up? Sorry about that. I'm sure I pressed the wrong button. But too much anxiety interferes with functioning, and we know now that it is bad for the brain. So when we have too much anxiety, a person has excessive worry, irrational fear, discomfort with others looking at them, stomach aches and bowel problems, physical symptoms of stress, headaches, tense muscles. We can see perfectionism, panic, and compulsive and repetitive behaviors. So what I would like to do now is, if I can, pull up a YouTube video for you to watch about anxiety, and it's really designed for children. I think it's a very good video, and it might be something that you want to use with the children you know. So I think I have to end my show to do this, but I'll be back with the PowerPoint.
Matthew Schuler. And welcome to Life Noggin. It's a few minutes before your big talk. Your hands start to shake. Your heart starts pounding. You, my friend, are feeling very anxious. But luckily, this is okay. Anxiety is a normal response to stressful or dangerous situations, and almost all of us have experienced it before. However, a smaller portion, about 18% of us, experience what is known as an anxiety disorder. This is a mental illness in which the anxiety lasts for at least 6 months and is characterized by distress that can interfere with a person's normal life.
Someone with this disorder may have their anxiety triggered by specific things called phobias, which lead to a person completely avoiding certain situations. Closely related to this is social anxiety disorder, which involves overwhelming worry about being judged by others or being embarrassed in public. On the other hand, some people may have generalized anxiety disorder, which involves persistent, excessive worry and tension that may not have an obvious trigger. And for people who get panic attacks, the feeling of terror strikes suddenly without warning.
But what's actually happening in the brain? Let's take a look. Well, a major player seems to be the amygdala, a pair of almond-shaped structures located deep in the brain. These guys are a part of the limbic system and are responsible for fear and other emotional reactions. The amygdala then tells the hypothalamus to initiate the fight or flight response. This results in the release of epinephrine, increasing the body's heart rate and blood pressure. The sympathetic nervous system then kicks into overdrive and produces some of the physical symptoms that we see in people with panic attacks.
Some studies suggest that in patients with generalized anxiety disorder, their amygdala are less connected to the areas of their brain that determine the importance of certain stimuli. This means that it may be harder for these people to distinguish between something that's mildly annoying and something that's definitely worth worrying about, like if you're going to be attacked by a giant snake, for example. Treatment usually involves some type of psychotherapy or different drugs. These conditions are very serious, so if you or someone you know may have an anxiety disorder or want to learn more, check out some of the links in the description.
So leave us some tips in the comments about how you deal with your anxiety. Whether it's mild or severe, we can all help each other out. Make sure you come back every Monday for a brand new video. And don't forget to check out Matt's awesome video on ways to treat anxiety. Check out his videos now, he's amazing. As always, I'm Blanco.
And I'm Matt.
This has been Life Noggin, and don't forget to keep on thinking.
So I hope you enjoyed that video. Matt has a series of videos about anxiety disorders really designed for children and adolescents. So I think they're well done, and they could be very useful in using with the children you either live with or work with. So let's talk about the frequency of anxiety disorders in children and adolescents. The lifetime prevalence for anxiety disorders is high. Now, this is throughout the lifespan. About 28% of adults will have an anxiety disorder at some point in their lives. And the prevalence between those ages 13 to 18 is 25%. That's over the course of their teenage years. That doesn't mean in any one year that 25% of teenagers will have anxiety, but over the course of the teenage years, about 25% will experience anxiety. And the median age of onset, meaning the age at which 50% have experienced anxiety, is 11 years of age. And I apologize, for some reason my charts aren't showing up, but on the last two slides, it just shows the prevalence of anxiety disorders. And we know that that the prevalence of anxiety disorders tends to be greater in the Hispanic population than in the African American, and it is greater in females than in males. So what's the takeaway message? Anxiety disorders are common, onset is early, usually by adolescence, and the condition is chronic without intervention. Anxiety disorders take many forms. Adjustment disorders with anxiety, separation anxiety disorder, generalized anxiety disorder, social anxiety disorder, specific phobias, panic disorder, obsessive compulsive disorder, and post-traumatic stress disorder, or PTSD. Anxiety may also be related to situational stress, or adjustment disorder with anxiety is a term we use when it appears that the anxiety is related to a situational stress or an environmental factor. This can be seen in individuals, for example, who have a condition like ADHD that's been untreated, or a learning disorder untreated. We can see it when there's the death of a parent, a loved one, parental divorce. It can be related to school stressors, and these children go talk to the nurse a lot, and it can go along with physical symptoms of stress and avoidance of situations. But the concept with an adjustment disorder is that this may be a transient condition reflecting stress in some area of a child's life. Separation anxiety disorder is another common form of anxiety in which the child has excessive anxiety about separation from attachment figures. Their reactions are extreme and more than we'd expect for their child's age, and there is unrealistic worry about harm to themselves or their parents when they're apart. So it's not unusual to see a child have separation anxiety when they're first taken to a preschool program at age 2 or 3 or 4. But typically, children get over that pretty quickly. They calm down and enjoy the activities, and then learn that they can go to preschool and their parents are going to come back and get them. So in the typical child, that separation problem won't last for more than 1 or 2 times, and they resolve pretty quickly once the parent's gone and the child starts to enjoy what's going on. We know that many children with separation anxiety have school refusal, and it's something that at CRG we see fairly frequently, and what we find is that if it goes on very long, it gets even harder to get the child to school. We know that children with separation anxiety disorder are reluctant to sleep alone or away from their parents. They may have nightmares with themes of separation, and again, they have the physical complaints. We see separation anxiety more often in children prior to puberty. It is less common to emerge in adolescence. We see it fairly equally in males and females, and there does seem to be some association with panic disorder later in life. We see a lot of separation anxiety in children with mood regulation disorders. So they have a lot of trouble separating, usually from the mother, but then the mother also will be the person that gets a lot of their anger. Specific phobias are anxieties that are associated with certain objects or situations. These usually emerge in elementary school, and some common fears include fear of dogs, even though they may not have ever been bitten, people breaking into their home, heights. These fears are excessive and out of proportion to the situation, and they are beyond voluntary control. They will lead to avoidance. For example, a child who's fearful of dogs won't go to people's houses for fear there will be a dog. And these phobias will persist over time, and they really can become quite maladaptive. Social anxiety disorder is an extreme form of shyness, and it is a fairly common anxiety disorder in children and adolescents, and it often does continue into adulthood. It is an intense, irrational fear of social situations or performing in front of others. We often will see that individuals with social anxiety disorder become very upset when they're children and they're put in a school performance. They may be very good at a sport or at acting or singing, but won't do it in front of others. They often don't like to eat in front of others, go to the bathroom in public places. Some very common activities can be very stressful for them. These individuals anticipate humiliation and embarrassment. It is more common in females than in males. And we can see the onset at a fairly young age and often persists through teen years and into adulthood. There's usually a chronic course, and as individuals with social anxiety get older, we will see that they will self-medicate with alcohol. Alcohol seems to make them relax and they're more comfortable going into social situations, but it's not a very effective coping mechanism. Selective mutism is an extreme form of social phobia or social anxiety. And in children who have selective mutism, we find that they do not talk outside of the home or to unfamiliar people. They will often smile in response to people talking to them. I think it's really an anxiety response. And so adults often will interpret their lack of responding or lack of talking as kind of a manipulative, willful behavior, but they are actually physically not able to talk in these situations. They understand language and very often have normal language development. And at home, parents often describe them as a chatterbox, talking all the time, very animated. But outside of the home, people may not see that. So their overall behavior and interaction is very restricted. But typically within the home, their interactions and emotions are within the normal limit. I've seen children that literally go all the way through school never talking in school. They don't cause behavior problems, And so oftentimes, they're just interpreted as being extremely shy, um, and are not pressed to talk. Generalized anxiety disorder is what we refer to as what-if thinking. Children with generalized anxiety disorder have unrealistic worry about future events. If they listen to the news, and many of them will, they will worry that the terrorists are going to show up in their home, or that they're going to get the symptoms of an epidemic happening in another country. So they worry excessively about things that are really beyond their control and are very unlikely to happen in their situation. They worry about their competence, they worry about their school performance, they worry about their future, and their heads just filled with all these what ifs. They often will have a perfectionistic quality to their work. Many times we find that they can't start a project or an essay at school because they worry it's not going to be good enough. So they have a lot of self-consciousness about their performance, and they worry excessively about themselves, and this often can interfere with their attention concentration. We get a lot of somatic complaints, headaches, gastrointestinal problems, muscle tension, and the child has a difficult time worrying. We see this up until adolescence. It seems to be fairly equal in males and females, but then as we get into adolescence and adulthood, much more common in females. Panic disorder. I think most people have experienced, or many people have experienced, a panic attack, which is a discrete period of intense fear with physical symptoms. Many times people think they're having a heart attack. If you've had one panic attack, it's very uncomfortable. But we see children, and especially as they get into adolescence, who will have multiple panic attacks, and they can have shortness of breath, sweating, tremors, nausea, dizziness. They really feel ill. They occur unexpectedly, and to be diagnosed with a panic disorder, you have to have one attack a week for 1 month or more, and then a persistent fear of having other panic attacks. The age of onset is usually in later adolescence, and the individuals will avoid situations in which the panic has occurred. If this goes on for a long time, we find that these people will start to avoid leaving the home because they don't want to get into situations where they might have a panic attack. Obsessive compulsive disorder, or OCD, involve obsessions, which are recurrent, persistent thoughts that are intrusive. The person with OCD knows that they don't make sense. And then the compulsions follow their repetitive, purposeful behaviors or rituals that frequently go along with the obsessions. We typically see multiple obsessions and compulsions, and people with OCD who don't have autism are self-conscious about their OCD, and this increases with age. Most adults who have OCD will report they had an onset as a younger child. The average age of onset is just prior to adolescence. They're less likely, obsessions are less likely in younger children. Children will often try to get parents to engage in their compulsive rituals. For example, if the child's reading a book and they make a mistake, or the parent's reading a book and make a mistake, they want to go back and start over. We know that OCD is familial, and that there's dysregulation in the serotonin and the dopamine. So what are some common obsessions? Well, we all know about hand washing or fear of contamination. People will have fears that they'll be aggressive towards someone even though even though they love that person and they don't think they would. They have obsessions about religion, safety and harm, need for exactness, and body fears, fears of illnesses or something going wrong with their body. And what are the common compulsions? Well, they check the thing they're worried about. Are the doors locked? Is the gasoline put away correctly in the garage? They clean and wash, they count, they repeat acts, they need to order and arrange things exactly, and they can be hoarders and collectors. Post-traumatic stress disorder is a condition that is getting more and more attention as we recognize the impact on individuals from traumatic situations. More recently, we've recognized the impact of PTSD on children. However, PTSD can occur at any age, and it's caused by extreme stress or trauma, and it can involve threat of death, physical attack or abuse. It can really, almost anything can cause PTSD, any stressful situation. And it can be a result of a single incident or reoccurring chronic incidents. People with PTSD re-experience the trauma. They have nightmares, or they repeatedly have thoughts that occur about the traumatic event. They want to avoid factors related to the trauma rather than deal with them, and they have a kind of a chronically increased arousal, or they're on their fight or flight action is kind of always present. Well, we've talked about the bad news, but the good news is anxiety is highly treatable. A study was just published in the American Psychologist, which is the journal of the American Psychological Association, and they did a meta-analysis of all of the interventions with childhood disorders, ADHD, mood regulation disorders, autism, oppositional defiant disorder, and the most robust findings for psychological intervention, not medication, but more psychological interventions, were in youth with anxiety. So we know that anxiety is very treatable, both with psychotherapy or other therapeutic interventions and medication. And actually, as I said earlier, it's probably one of the most treatable situations. So who is at risk for anxiety? Well, we know that children who have behavioral inhibition in childhood are at risk. So children that are reserved, temperamentally shy, avoidant, don't like to leave home, be with strangers, they are more likely to experience anxiety. We know that being female puts people more at risk. Having few economic resources, because there really are risk factors and fear of just being taken care of, and being exposed to stressful life events. Parental history of psychiatric disorders puts a child at risk. And while certainly we know anxiety disorders run in families, there also seems to be a increased likelihood of anxiety if parents have known depression or other psychiatric conditions. So the genetic predisposition is strong. And children who have other psychiatric diagnoses or learning disorders are at risk. So what do we look for as signs of anxiety in youth? Well, outward nervousness like nail biting, refusal to speak in some situations, trouble concentrating when stressed, stomach aches, headaches, physical symptoms, avoidance, anger and aggression when pushed into situations that are anxiety provoking. I always use the example of, so my phobia is of rodents. I hate mice, rats, squirrels, any little furry animal that darts around. And if someone tried to get me to go into a room where I knew there might be a rodent, I could get pretty aggressive. And that's how children are when we try to push them into the situations that cause them anxiety. They may not be a child who's normally aggressive, but if you push them towards something anxiety provoking, they can get aggressive. So what are common coexisting conditions? Well, really, as I said earlier, any other psychiatric or mental health condition. ADHD, particularly females with ADHD, are at very high risk of developing anxiety disorders. The CRG newsletter will be coming out next week, and there is an article about coexisting condition in females with ADHD, and anxiety rates in females with ADHD very high. If you have one anxiety disorder, you're likely to have other anxiety disorders. So it's not unusual for us when we're seeing a child who has an anxiety disorder to be coding or diagnosing 2 or 3 anxiety disorders. As I said earlier, children with mood regulation disorders almost always have some degree of anxiety. And neurodevelopmental disorders such as intellectual disabilities, autism spectrum disorder, and specific learning disorders are at high risk for having anxiety. It is seldom that you will see a child who just has a single anxiety disorder and no other coexisting conditions. So, at least 1/3 of children with anxiety disorders meet criteria for 2 or more anxiety disorders. Depression frequently coexists with rates up to almost 70%. Too much anxiety for too long will often spill over into depression. 15 to 24% of children with separation anxiety or generalized anxiety also have ADHD. And severe anxiety at a young age may be the precursor to an underlying mood disorder, such as disruptive mood dysregulation disorder. So, youth with anxiety just have more difficulty realistically assessing danger. They have their antenna out, constantly seeking for sources of danger. They often respond to the perceived stress before even thinking about it. So their emotional brain, or the amygdala, doesn't even let the thought get up to the thinking brain to assess how they should respond. They can be easily discouraged and give up, and they have trouble with self-calming once they are upset. So how do we treat anxiety? Well, I think that just like with any condition of childhood, or probably adulthood as well, we start with thorough assessment. And thorough assessment means at least standing back and asking the questions that we need to ask clinically and of parents about the likelihood of another condition that might be going on. We need to educate the parents, the caregivers, the teachers about anxiety, about the child's anxiety, and how they can help and intervene. We need to educate the child or adolescent about their anxiety at the level they can understand. And that's really why I like that YouTube video I showed you earlier. I think that's at a level that a child in late elementary school or middle school could understand and begin to understand what happens to them when they become anxious. It kind of normalizes it, that they're not the only one with this condition, and sets the stage for them being able to talk about and identify anxiety and the sources of anxiety. We need to build support in at the points of stress. So if a child is anxious about school, we need to determine what's happening at school that makes them anxious and build support in at that point. We can't talk about it at home or in an office without doing something in the location it's occurring. We use cognitive behavioral interventions to assist with anxiety, and often we consider medication. I think the one thing I want to emphasize is that anxiety is a condition that, if it persists too long, can have a very negative impact on development, on the parent's ability to parent normally, but also on the brain. So this is a brain-based condition, and we do need to address it, usually first through cognitive behavioral intervention, but then sometimes medication is appropriate to assist with improvement. So what's the adult role in treatment? Well, I think first, adults need to recognize that the child is not choosing to be anxious, and they cannot easily get over it. If the adult has never experienced the type of anxiety the child has, this might be difficult for them. In the references, I list a book that's called Worry by Ed Hallowell, and it is a great book to help people understand anxiety if they themselves don't experience it. Adults need to minimize, but not totally eliminate, sources of anxiety. So, for example, if a child's fearful of dogs, the family shouldn't avoid all houses with dogs, but they should try to get the child near a dog in a less stressful environment, or when the dog is being held by the owner so that it's not going to dart at the child, and try to get them to become more and more comfortable around one or two particular dogs in hope that that will generalize to others. And then I think it's important, especially for parents, to think about their own anxiety. It's very important that adults not let their own anxiety flow into the child. So the child may have an anxiety disorder, but it's the adult's responsibility to remain calm and not reinforce that anxiety. Because, as we often say in our office, there's only room for one hand on the panic button. And if the child is anxious and that makes the adult anxious, or vice versa, then the thinking brain is not going to kick in. Adults need to be supportive, they need to empathize, but don't jump into the same anxiety with the child. You can identify, oh, I used to worry about that, and these are some things that happened that I found helped, but don't reinforce that I have the same anxiety. Provide consistency and routine. I could probably say this in any presentation I give about children, regardless of the disorder, but consistency and routine helps children with anxiety feel more in control. We often need to also slow down. Expect less based on what others expect, but expect age-appropriate behaviors. What I mean by that is that we live in a world where I think we're often often expecting children to be able to do and perform and engage in situations that are really beyond what they should be able to do for their age. So sometimes we just need to slow down. We need to make life a little simpler for children with anxiety and recognize that not every child can perform at a high level day in and day out. So kind of accept what where the child is, and slowly lead them to the next step. So what are some classroom strategies? I know we have some teachers on the call, so one of the terms teachers see frequently is preferential seating near the teacher. And pretty soon we're going to run out of those seats up near the teacher. But children with anxiety should be seated fairly near the teacher so the teacher can be accessible when needed and away from students who are provoking. Children with anxiety will do best in a classroom where there is structure and external and support and emotional warmth. They will do well in small group learning and social opportunities. So if they have social anxiety, when they go out to recess, they may need help finding a small group who would be welcoming to them. They need praise, and they need a lot of feedback from others about how when they're doing well. They often get overwhelmed when there's too much to do at one time. So if tasks or assignments can be broken into smaller pieces, that can be helpful. Again, predictability. If they get upset when they're given feedback, try to help clarify what you've said. They may only hear the negative, so you need to make sure they hear the positive. And of course, as with any child, we need to avoid public criticism or putting them into situations that will make them, quote, look bad to their peers. So I have listed a few references. And at this point in time, we just have a little bit of time left. I'm going to open this up to questions. If anyone has questions, and I think I have a few here. So the first question I see is, are there any videos for younger children, like a second grader? You know, when I was doing a search, I did see some. There were quite a few. If you just go in and Google anxiety in the brain on YouTube, there are quite a few. I saw one, and this may have dealt more with anger, that was about angry birds. There are quite a few on there. So I think it's worth getting on and looking and see what you see. Other questions, let's see, here's one. Do we ever pair traditional therapies with acupuncture or tapping? So I think what I would say is that in our office, we don't intentionally pair them together. I mean, what I always tell parents is, if you're doing the things we know will help, like therapy, like cognitive behavioral therapy and appropriate parenting and making sure the school situation is appropriate for the child, there are some therapies that families want to pursue, and as long as it doesn't keep the family from doing what we know works and isn't harmful, sometimes families will pursue other options. But I don't know, I don't think I intentionally recommend the pairing of those, especially if I'm not sure that there's data to support that the other therapies work. Any other questions? Okay, here's Okay. Oh, I can tell this is a loaded question. Do you think social media, Instagram, Snapchat make social anxiety worse in a teenager? Yes. I think it makes social anxiety, causes social anxiety in teenagers who don't have um, social anxiety, because I think the teenagers are always comparing themselves to others. I have a sign in my office, and I should have put it on a slide probably, but the sign in my office says, "May your life someday be as awesome as you pretend it is on Facebook." And I think what teenagers and probably college students and adults do is they look at what everyone else is doing and think their life is horrible, or they're not popular, or they don't have friends compared to other people. And yet what we have to help young people understand is people are only posting the positive things. So I would love to see all of those limited, but I know that's a huge task. Just FYI, I think that we're hoping next fall, CRG will be sponsoring a community event and airing a video entitled Screenagers, and then we'll follow it with small group discussion about electronics and social media with teenagers. So if you're on our constant contact list, of course you'll hear about that. But I think we're hoping to do that next September or October. Okay, what types of medication are typically prescribed for children on ADHD medicine that are experiencing anxiety? Well, in treating children with anxiety disorders, we use the same medications that we would use with adults. And typically those are, not always, but typically they're going to be the selective serotonin reuptake inhibitors, or what we call SSRIs. Those are medicines like Zoloft, Lexapro, Prozac, and now there are probably 9 or 10 of those medications on the market. We do use them in conjunction with ADHD medicines. When we decrease anxiety, we sometimes see that the symptoms of ADHD become more apparent, so sometimes we have to adjust the ADHD medicine after we start an anxiety medicine. That doesn't mean the ADHD's gotten worse, it just means that the anxiety isn't controlling some of the ADHD as much. So it is not uncommon for children with ADHD to also be on an anxiety medication. Okay, are the slides available after the webinar? Yes. If you look on your screen, we did post a PDF form of the slides, so you can download those, and I hope those will have the graphs that didn't show up on my PowerPoint. If not, I'll see what I can do. We may have to repost those. And is there any sort of support for parents of children with anxiety? Well, that's a good question. We always have parents asking about that. To my knowledge, right now, there are no support groups in the Indianapolis area that I know of for anxiety disorders. We have been talking about the idea of having webinar or teleconference-based support groups down the road, so stay tuned. There certainly are some chat rooms out there, and at the end of, again, on the references, I've listed some websites, particularly those that deal with anxiety, might have parent chat rooms or a way to connect. Long-term problems with medication use. Oh, I'm not sure I can answer that in this short time. So I think long-term problem with medication use, typically long-term medication use for ADHD or anxiety will not have long-term effects. and often it's important to look at the effects of not treating versus treating. So I won't go into it much more, but I guess what I would say is, if you get on and start researching the anxiety disorders and the brain, what you'll find is that untreated anxiety or stress starts to have both structural and neurochemical changes on the brain that aren't good. So you have to weigh that against the side effects of medications, most of which are what I would call nuisance side effects. But again, we don't use medication lightly. And here's a question: how do we determine when medication is needed versus just therapy? Well, I think, certainly rule of thumb, or my rule of thumb, and I think this would probably be common to most people who treat children, is that anxiety disorders are often very responsive to cognitive behavioral therapy. And so and obviously parents have to be involved in that as well as the child. So it's usually working both with the child and the parent, especially in young children. We're almost always going to start with therapy, unless the anxiety is so impairing that we have to use medication to just start to get through the days or get to school. And then we come back around and add the therapy, and then determine whether we can decrease medication. But again, just remember, anxiety is often very responsive to therapy, and usually we're going to start there. Okay. Student was given ADHD meds and became anxious. Anxiety meds became suicidal. Depression meds hospitalized due to fear of harm to self and others. Took off all meds, anxiety, depression better, but ADHD through the roof. Great comment. Well, again, I don't think I know this young person, because I know who asked the question, and I don't think I know that person. But I would say that's where I think you back up and you make sure there's been a comprehensive evaluation of what is going on. I think all too often conditions are treated with medication without a comprehensive evaluation. Let me bring up a case in point. Yesterday we saw a young man in our office he's been diagnosed with ADHD, anxiety, and depression. And his IQ is in the lower 1% of the population, and he's in a general education classroom setting. Well, he's of course anxious. He can't do the work expected. So I don't think any amount of medicine is going to take away his anxiety in those situations. So obviously I don't know the child that was referenced here, but I would say stand back. And oftentimes, or we could be dealing with a more severe psychiatric condition that got exacerbated by ADHD medications and antidepressants. And another question: are sleep difficulties more common? Are more common in individuals with anxiety? Yes. And what I always tell the families I work with is those with anxiety have trouble falling asleep, and no one lays awake in bed and has good thoughts. You're always, even people without anxiety disorders, if they can't sleep, they're thinking about all the things they need to do or all the things that went wrong that day or might go wrong. And so the inability to fall asleep is a problem for those with anxiety disorders, and oftentimes we recommend that the individual use melatonin just to help them fall asleep so that they don't lay awake worrying. And the person who asked about the child who had ADHD and then anxiety and then depression and suicidal thoughts, did just say they didn't come to CRG, so I'm glad to hear that. I'm glad that it wasn't one of my clients that happened to. So I want to thank all of you for joining us today. This will be posted on our website for if people want to reference it in the future. I know we covered a lot of basic information about anxiety disorders, and obviously the treatment, both with therapy and medication, gets a little more complex. But for those of you who work with children or have children, I hope this has been helpful in letting you better understand the child's difficulties and know how you might intervene. So I hope you have a good day. Many of you are probably getting ready for a spring break, so I hope you enjoy some nice weather somewhere else or a good time at home, and I wish you well. Thank you.